First question. A baby is delivered by a cesarean section at 31 weeks of gestation. The child has tachypnea, nasal flaring, and subcostal and intercostal retraction. A nasogastric tube was positioned without problems. Chest radiography shows bilateral, diffuse ground glass appearance, air bronchograms, and poor lung expansion. What is the best treatment plan in this case? All of you have answered C, so we just go with that. So the first question, most of you got this right. Baby is delivered via C-section at 31 weeks of gestation, implying that it is a preterm delivery. So any baby that is born before 37 completed weeks of gestation implies it's going to be a preterm baby. Okay, so one of the most common complications associated with that is your neonatal respiratory distress syndrome, which is exactly what is mentioned in this stem. So they mentioned the child has tachypnea, nasal flaring, subcostal and intercostal retraction. So any question you come across which mentions, nasal flaring and subcostal or intercostal retraction, automatically think of an increased work of breathing. So in this case, they're trying to imply that, the baby has to make an additional effort to breathe. So implying that the baby has gone for respiratory distress. And based on that, the best mode of treatment is your surfactant administration and oxygen therapy. Option A says oxygen therapy on its own, but since this baby is born before surfactant levels actually peak, okay, because usually it starts producing around 31 to 32 weeks and peaks at around 35 to 37 weeks. So since the baby is being deprived of the surfactant, it is better to administer it. Okay, so that's why option C is better than option A. Option B, which says no immediate treatment, observation only, is completely false. If you would not take care of a baby in respiratory distress, chances are the baby will die very soon. So option B is a no-go. Option D, which is antibiotics. Yeah, antibiotics are important, especially if the baby is put on mechanical ventilation because of the increased risk of infection as well as aspiration pneumonitis. But that is only something that sort of comes in like the further management. First line of management is, only along the lines of administering surfactant and oxygen. Okay, and emergency surgical repair of tracheoesophageal fistula. So babies that are born with tracheoesophageal fistula also do present with a very sort of, similar presentation. They will have some sort of respiratory distress, but they will also have cyanosis. And the main thing in this question that sort of rules out, okay, the diagnosis of a TEF is the fact that it says a nasal gastric tube was positioned without problems. So the main reason they're giving this is for you to rule out tracheoesophageal fistulas, because if the baby had a fistula, nasal gastric tube will not be able to reach the stomach, most probably because in most cases of TEF, the proximal part of the esophagus is actually atretic. It's only the distal part that actually forms the fistula, so sort of the H shape. So if the esophagus is atretic, it's not going to reach the stomach. But here in this case, it's passing without any difficulty. So you can very, very easily rule out TEF. And as a result of that, option C is the best.